Hi everyone, this is Dr. Madhusudan Rao. On the program, I teach medical students. Today's topic is on jugular venous pressure. This is part of the clinical examination of cardiovascular system, and the student should learn how to elicit jugular venous pressure. So the picture shows the patient is kept in the supine position with the head end of the bed elevated to 45 degrees. Examine the vertical column of pulsations of the internal jugular vein on the right side. JVP or jugular venous pressure reflects the right atrial pressure changes. So how it is estimated? It is estimated as height of the vertical column from the top of the pulsations to the right atrium. So that means you are observing the internal jugular vein pulsations on the right side. Measure the height of the vertical column from the top of the pulsations to the right atrium. So you will observe the wave pattern of the internal jugular vein between the sternal end of the clavicle and the ear. So this vein runs under the sternocleidomastoid muscle. So internal jugular vein lies internal to the external jugular vein, and you'll find two waves for each heartbeat. These waves are better seen than palpable. Then if you put the pressure over the right upper quadrant of the abdomen, you will observe a rise in JVP. This is called hepatojugular reflex. So if you apply pressure over the medial end of the clavicle, the waves are obliterated. Why? Because you are putting the pressure over the internal jugular vein, thereby obstructing the flow of blood into the superior vena cava. So the pressure changes in the right atrium are obliterated or diminished. When there is increase in the right atrial pressure, as in heart failure, tricuspid regurgitation, constrictive pericarditis, you will observe rise in jugular venous pressure. And this sign is very difficult to find in children less than 8 years. So you always examine the children more than 8 years for this sign, that is jugular venous pressure. Then let us know a little bit about the anatomy of the internal jugular veins. So internal jugular veins are the large veins draining head and neck. They begin at the jural sinuses and exit from the cranium through jugular foramen, passes by the side of the carotids, joins subclavian vein, okay, ultimately empties into the right atrium via the superior vena cava. Whereas on the left side, the internal jugular vein communicates with the superior vena cava via the innominate vein before it empties into right atrium. So the changes of the pressure in the right atrium are better reflected on the right jugular vein pulsations instead of left jugular vein. So for JVP, you examine the wave pattern in the right jugular vein. External jugular vein is superficial, runs lateral to the internal jugular vein, drains scalp, neck, and face, and runs diagonally over the sternocleidomastoid muscle, whereas the internal jugular vein lies deeper to the sternocleidomastoid on the right side as well as on the left side. Okay. Another important anatomical landmark is sternal angle of Lewis. It is the junction of manubrium with the body of the sternum. Second rib joins at the sternum, and this point is near 5 centimeters vertically from the right atrium. And if you see this picture, it denotes the right internal jugular vein, which is directly communicating to the right atrium via the superior vena cava. So, what is the physiology? So, as I told you, JVP reflects the pressure changes in the right atrium. And what you observe in the JVP tracing is the wave pattern of the internal jugular vein. So the wave pattern can be explained by the mnemonic ask me. So before we go to the mechanism of the wave pattern, so let us see what are the waves in the jugular venous pulse tracing. This is the JVP wave pattern. You find 3 positive waves, A wave, C wave, and V wave. And there are 2 negative waves, X and Y. So what is the mechanism of these waves? How they are produced? So how they reflect the changes in the right atrium. So A wave is positive wave, indicating the increase in the right atrial pressure. So right atrial pressure increases during atrial filling. Atrial filling occurs due to the systemic venous return into the right atrium. So when the atrium is getting filled due to venous return, the pressure gradually increases in the right atrium and results in the slow rise of the A wave, and the peak of the A wave reflects the maximal pressure in the right atrium during atrial systole. Okay, if the atrium is contracting against the narrow tricuspid valve, so it will result in the peak A wave because of the rise in the intra-atrial pressure. So A wave indicates atrial filling followed by atrial contraction, right? The ascending limb of the A wave is due to the gradual rise in the intra-atrial pressure due to venous return, and the peak of the A wave indicates atrial contraction. So then next wave is the C wave. C wave is due to systole, that is ventricular systole. During the ventricular systole, there is pushing of the tricuspid wall or the movement of the tricuspid wall into the right atrium, thereby causing the rise in the intra-atrial pressure, because the atrium is already slowly getting filled, and there is ventricle is contracting with the push of the tricuspid wall into the atrium, that results in a subtle change in the rise of the intra-atrial pressure. That results in a positive wave, a small wave called C wave. Then you will find another positive wave, V wave. V wave occurs due to the maximal atrial filling because atrium is continuously getting filled, and at the peak of the atrial filling, at the point of atrial contraction, you find the A wave. So atrial contraction is followed by the atrial diastole. Okay, during which phase, this phase, there is ventricular systole, that is early phase of the ventricular systole, which results in the pushing of the tricuspid wall a bit into the right atrium, because early ventricular systole results in closure of the AV walls. Okay, so during this phenomena, tricuspid valve is pushed a little into the atrium, thereby resulting in this slight rise in the intra-atrial pressure, which results in C wave. The next one is the K. K stands for closed tricuspid valves. During this phase, stage, there is a gradual filling of the atrium, and the filling reaches to the maximum level, resulting in V wave. At the point of maximum atrial filling, there is a rise in the intra-atrial pressure, resulting in the positive wave, that is V wave. Then it is followed by emptying of the right atrium during the ventricular diastole, wherein tricuspid walls open and there is early rapid filling of the ventricles due to flow of blood from the atria into the ventricles. So there is a sudden drop in the intra-atrial pressure, resulting in a negative wave in the JVP tracing, that is Y wave, due to fall in the intra-atrial pressure in the right atrium. Right. This is the mechanism of the various waves that you see in the JVP tracings. And this simply can be explained as filling, contraction, emptying, relaxation of the right atrium. So this phenomena results in changes in the right atrium, which are reflected as wave pattern in the internal jugular vein on the right side. So this is how the JVP is elicited and examined and understood by the students. So this tracing again reflects the A wave, C wave, V wave as positive waves, and X and Y as the negative waves. This is the JVP wave pattern, which I explained already. This has to be remembered by the students. A wave indicating the rise in the intra-atrial pressure during atrial filling and the atrial contraction. C wave reflecting the ventricular systole, the movement of the tricuspid wall into the right atrium, thereby resulting in rise in the intra-atrial pressure on the right side. And V wave indicates the maximal filling of the right atrium, resulting in rise in the right atrial pressure, reflected as the positive V wave. Y descent is because of the emptying of the right atrium during the early rapid filling of the ventricular chambers, during ventricular diastole. Thereby, blood from the atria is passing into the ventricular chamber with the gradual fall of the right atrial pressure resulting in negative Y wave. So this is the wave pattern of the jugular venous pressure and the mechanism underlying it with the changes in the right atrial pressure. So what are the indications in which you are called to examine the JVP? There it says one is routine examination and two is to measure the central venous pressure. You will find the changes in the JVP during the examination of the patient with the clinical conditions like congestive heart failure, tricuspid stenosis, pericardial effusion, constrictive pericarditis, superior vena cava obstruction, and pulmonary arterial hypertension, and tricuspid regurgitation. What are the changes you note, you observe? In all the conditions except in tricuspid regurgitation, you find the prominent A waves. And in tricuspid regurgitation, V wave is very much prominent. Okay, the mechanism is very simple. In all the conditions wherein A wave is prominent, there is increase in the right atrial pressure. Okay, thereby producing, producing the prominent A waves. In tricuspid regurgitation also there is increase in the intra-atrial pressure, but it occurs during the ventricular systole, because in this condition, that is tricuspid regurgitation, there is a retrograde flow of the blood from the right ventricle into the right atrium, resulting in the tall, prominent V waves. Because the regurgitant blood adds to the blood that is already existing in the right atrium due to venous return. The V wave is normally produced due to the maximal filling of the right atrium due to venous return, and this is added by the regurgitant flow of blood from the right ventricle into the right atrium in tricuspid regurgitation, resulting in very prominent V wave. This is the explanation behind it. Whereas in rest of the conditions, it is the rise in right atrial pressure occurs during atrial systole, resulting in prominent A waves. Hope you could understand the mechanism under which these changes occurs in JVP during these clinical situations. So you have got to observe the technique to examine the patient for JVP. So you keep the patient relaxed, lying supine, with head end of the bed elevated to 45 degrees as you have seen in the picture. Slightly turn the head to the left side. The most important point is adjust the angle of the bed till you see the pulsation or pulsatile column of the internal jugular vein. That is, you should have noticed the top of the pulsatile column of the internal jugular vein on the right side. And observe for the pulsations at the suprasternal notch. Then proceed to measure the column height from the Lewis angle to the top of the pulsatile column. This height is normally less than 3 centimeters, but if it is more than 4 centimeters, it is abnormal. It is increased in the are elevated in the conditions which I explained before, like volume overload, obstruction to the superior vena cava, tricuspid stenosis, pulmonary hypertension, pulmonary stenosis. In all these conditions, the A wave is very much prominent, associated with deep wide descent. Steep wide descent, yes. So if you can observe the prominent A wave, you are dealing with the situation wherein there is increase in the right atrial pressure more than normal. And the clinical condition you are encountering during the examination is probably a case of volume overload, a case of tricuspid stenosis, a case of constrictive pericarditis, etc., wherein there is rise in the intra-atrial pressure during the phase of atrial filling and also atrial contraction, resulting in prominent A waves. This how you have got to interpret the changes in the JVP, either change in the A wave with steep rise or change in the V wave which is associated with the tricuspid regurgitation as a rise in or elevated or prominent V wave. So this is the pulse tracing of the jugular venous pulsations showing the wave patterns. So there are positive waves as ACV, the mechanism which I have already explained. So keep these points in mind before you interpret the changes in the jugular venous pulsations to correlate with the clinical condition of the patient to help assist you in the provisional diagnosis of the case under examination. So, my dear students, hope you are able to understand the JVP and the wave pattern and mechanism of these waves in the jugular venous pressure reflecting the changes in the right atrial pressure. Thank you very much for patient listening. If you like this video, please subscribe to my channel. Thank you very much. We'll meet again in the next class. Until that time, bye-bye.